So, without further ado, welcome to this monthly lecture, Learning Human Anatomy as a Medical Student, with our guest speaker, Danya Stone. Danya has been an anatomy lecturer at BSMS since 2019. She primarily delivers anatomy teaching to first and second year medical students and leads the anatomy teaching for Module 103, Hearts, Lungs and Blood. Danya also contributes to teaching on biomedical science and medical education courses, as well as the Physician Associate Programme. And she has an interest in anatomy education research and is currently completing a part-time PhD that explores the emotional experience of medical students during their first session in the dissection room. So without further ado, I'll hand you all over to Danya.
Lovely. Thank you very much. And thank you so much to everyone that's given up a bit of their evening to listen to me talk about anatomy. I'm just going to quickly share my screen. And unless I hear otherwise, I'm going to just assume that is all working okay. So today, this talk will be in two parts, really. I'm going to spend the first half an hour or so talking about how anatomy is taught, a bit about the history of cadaveric dissection, and a little bit about what we do specifically at BSMS to teach anatomy. And then I'm going to move on to give a little demo of how I would teach an introduction to head and neck anatomy using our 3D model, Complete Anatomy. So just to give you a little taster of how anatomy is taught and what it's like to learn anatomy. So I've put my name and email address there, and I do welcome any emails from anyone that wants to get in touch, whether you have questions or just want to make a comment about anything that I cover today. I do welcome anyone getting in contact. So questions today, you've already heard there's a Q&A function. I will stop at the point where I move from talking about anatomy and dissection into the kind of demo lesson. So I will pick up any questions waiting for me at that point then, but I will also try my very best to leave a good amount of time at the end as well, so we can answer some more of those questions. So I've included this slide because this presentation does include a couple of images of cadaveric specimens, and all of these are in the public domain. So this slide doesn't really apply to this presentation. It's okay for these to be shared on social media and screenshots to be taken. But I just thought it was a really good point at which to get you all to think about how we normally view and treat images of cadavers. So specifically the cadavers we have at BSMS. So we ask our donors if they will consent to us taking images. And if they say yes, we're able to use those images for education, so we can use them in our lectures. But when we do this, it's really, really important that our medical students are really consider the fact that what they're looking at is a human donor. So we ask them not to take screenshots. We ask them not to put anything on social media at all. And one that applies for today as well is just to think about who's around you and who can see your screen. Not everyone wants to see these images popping up, and it's just a really good thing to be aware of when learning or thinking about anything to do with cadaveric dissection. So I'm just going to start off with a brief history of dissection, because it helps us understand where we are today in how we think about dissection when we're teaching anatomy. So we're going way, way back here, and ancient Greece in the 3rd century BC is the first documented evidence that we have of anatomists practicing dissection. Before then, the whole practice was shrouded in a lot of taboo, and people really didn't engage with it at all. But we get to the period particularly of Herophilus, who is known as one of the first anatomists and is one of the first documented anatomists to practice learning anatomy and teaching anatomy through cadaveric dissection. However, after the death of Herophilus, and at the same time there was a big increase in Christianity in the church all across Europe, it meant that dissection really fell out of fashion. No one was doing it. It was absolutely prohibited, and the church described it as blasphemous. So we went through a very long period where no one was performing cadaveric dissection. And within this period, oh, sorry, I forgot that image was there. So this image just shows you an example or a painting from what dissection might look like during this period. And it looks very different today, as we'll see in a little bit. So during this period of no dissection being performed, but we're 129 AD now, so we've jumped forward a little bit. We have the birth of Galen. And Galen is thought of as one of the fathers of anatomy, so one of the first anatomists. And this is because he produced anatomical drawings. And these anatomical drawings were used for the next 1300 years, and they were undisputed. However, we've already stated that no cadaveric dissection was taking place at this time. And Galen was actually performing these dissections on apes or other animals such as pigs. So in the image that I've put up here, it's actually Galen dissecting a pig. And a lot of his anatomical drawings, therefore, were based off of the animal anatomy. And while he thought that everything was much the same between animals and humans, and while that is amazingly true a lot of the time, it probably won't surprise you to find out that there are a lot of differences as well. There was a real turning point in 1231 AD with the Holy Roman Emperor Frederick II. And he stated that every person practicing medicine should attend a public dissection at least once every 5 years. So this led to a huge upsurgence in the amount of cadaveric dissection that was being performed. And this spread throughout Europe quite quickly. So this leads us on to Vesalius then, and you might have heard of Vesalius, very, very famous still in the world of anatomy, considered the modern father of anatomy. And Vesalius was performing cadaveric dissection. So unlike Galen, who was dissecting animals, Vesalius was now dissecting humans. And we have a picture here of Vesalius performing a dissection with a lot of people around. And what was very different in this period compared to now is these people could be students, but they could also be members of the public. So it was very common for members of the public to be invited in to observe these dissections taking place. And what I find really interesting is if you see the sheet of paper that he's referring to, the textbook with the drawing on it, that's actually Galen's text that he's referring to. But it was Vesalius that was the first to really highlight the inaccuracies in Galen's work. So he identified over 200 inaccuracies in what Galen had produced, and he himself produced a new anatomical text that's still regarded very highly even today. So jumping forward quite a lot now, up until this point, there was no legislation around the way that bodies were acquired for anatomy dissection. And a lot of the time it was just whatever the anatomist could source is what they would use. So a lot of it was unclaimed bodies or executed criminals. And in 1751, there was a whole series of murders that took place within London. And so in response, the Murder Act was brought out. And the Murder Act placed public dissection as the top punishment possible for anyone. So it was reserved just for people that committed murders and then were executed subsequently. So it really changed the public perception of dissection. It was seen as the worst thing that could possibly happen to you as a consequence of one of the worst crimes you can commit. However, with it only being executed murderers, this did not fulfill the demand from anatomists for cadaveric dissection. And this meant that grave robbing at that time became really, really rife throughout the UK. And you might have all heard of Burke and Hare. So Burke and Hare started off grave robbing, and they were supplying the bodies to a Dr. Robert Knox, a very famous anatomist again, for the grand sum of £7.50, which doesn't sound like a lot today, but back then it would have covered about a month's rent, so a substantial amount of money. And Burke and Hare realised that a much easier way to acquire bodies rather than digging up the graves was actually just to murder people and hand them straight off to Dr. Robert Knox. So it's thought that Burke and Hare murdered 16 people and supplied them to the anatomist for the study of anatomy. And we have an image of Burke's skeleton here, because as we just spoke about, the Murder Act meant that public dissection was reserved only for people that had committed murders. So Burke himself ended up being publicly dissected. And the skeleton of William Burke can still be found in the Edinburgh Museum even today. Very shortly after, Burke and Hare were convicted, 1827. This led to the need, there was public outcry, there needed to be a new legislation to ensure that this never happened again. And this culminated in the Anatomy Act of 1832. And the Anatomy Act of 1832 attempted to find a way to provide more bodies for anatomists. And the way that they did that was they allowed anatomists to claim any bodies that had died in prisons, hospitals, or the workhouses. And if those bodies were unclaimed 48 hours after death, then they could be used for anatomy dissection. However, this was really unfortunate because unfortunately it meant that it was the poor that were then being dissected. And there was still this public perception that public dissection was reserved for the worst crimes possible. So really not an ideal solution at all. However, and there's a lot of debate as to why this happened, we don't really know, but at the turn of into the 1900s, there began to be people that were actually donating their bodies willingly to anatomy dissection. And in 1984, the Anatomy Act was updated, and now, in order to dissect a body, the person had to have either verbally or in writing consented to that activity taking place. The 1984 update also stated that bodies couldn't be kept for more than 3 years, and then they had to be returned, either buried or cremated, or returned to the family. Here I've just included a picture, and this is from early in the 1900s from an anatomy school in London, just to give you an idea of what the dissection would look like at this time. Very, very different again to how it looks today. So for one, we don't allow people to smoke pipes in our dissection room. You wouldn't find people with their feet up on the tables, and you would definitely find people wearing gloves and a lot more PPE than was required here. But other than that, it's remarkably quite similar to the setup that we see in this image. So that brings us on to today. What's the legislation and is it still used? Okay, so is cadaveric dissection still used to teach anatomy in the UK? And the answer is yes. So this is our lovely lab at Brighton and Sussex Medical School. Feel very, very lucky to work in such a modern lab. You can see it's very bright, the walls are white, everything's very clean. And all of this feeds into the legislation at the minute that we'll go through in a second. So you can see here we have our donors on tables around the room. We can also see the potted specimens that show quite often different pathologies around the side of the room. And all of these have been blurred out just because, again, we never share any of our human material publicly or online. So it might surprise you, I'm not sure, that 87% of UK and Irish medical schools still teach using cadavers in some form. So the large majority still teach using cadavers for at least part of their course. So it's something you might want to consider when applying to medical school. If it's something that you're really keen to participate in and learn anatomy through this method, then yeah, it's just something to make sure you're aware of between the different institutions in the UK and Ireland. There's two main formats to teaching through cadaveric dissection, or dissection or prosection, sorry. So the first one is dissection, and this is where students are provided with a guide, or there's a faculty member there to guide them through, and the students themselves dissect the body. So working with a scalpel and other instruments, they work through layer by layer and slowly reveal the structures that they need to see for that session. The other format that's commonly used is prosection sessions. And this just means that certain parts of the body have been professionally dissected. So this means that every single nerve that you need to study for that session will definitely be on this specimen, which doesn't always happen with dissection. So in prosection sessions, there'll be a range of different body parts that have all been professionally dissected, and then students move and have a look at all of them throughout the session. And when does this normally take place? So another thing just to be aware of is normally you're introduced to this kind of learning very early on in year one. And it tends to last throughout the preclinical years of the medicine course, so years 1 and 2 in most institutions. In some institutions, they have a spiral curriculum, so you'll revisit the anatomy during years 3, 4, and 5 as well. But almost always the bulk of the anatomy teaching is in years 1 and 2. And what is the current legislation? So the Anatomy Act was updated or replaced by the Human Tissue Act in 2004. And the Human Tissue Act is regulated by the Human Tissue Authority. So we have a lab that is licensed by the Human Tissue Authority, and it's regulated by the Human Tissue Authority. And we have 4 key guiding principles that guide everything we do in the anatomy lab. So the first one is consent, but not just consent, it has to be informed consent now. So whereas before in the Anatomy Act, we said that it had to be either written or verbal, now there are very specific ways that donors need to show they've given consent. And this just makes sure that every person giving consent fully understood what they were signing up to. So they're provided with all the information, they have an opportunity to ask questions, and any information they request is provided before they sign their consent. The second guiding principle that we follow, and really it's the one that feeds into everything we do all day, every day, is dignity. So donors should be treated with dignity at all times. Medical students are made very, very aware of this before they enter the lab for the first time, and that really is upheld in everything that we do. Dignity goes further as well to making sure that the lab is clean and organised, and the donors are stored in a way that means that they're well looked after. The next one is quality. So quality just means that the people that are allowed to work with the donors or the cadaveric material are trained in how to do so. But it also refers to the way in which we document everything. So we have very rigorous processes that make sure that every single part of every single donor is accounted for at all times. So we always know where everything is stored within the lab, and there's always paper trails to make sure that that is upheld. And finally, honesty and openness. So this works in 2 main ways. One, it relates back to the consent. If the donor has questions before donating, or the person has questions before making the donation, honesty and openness about what will happen to them is always upheld. But also honesty and openness between the institutions and the HTA is really, really important. So say there ever was an incident, it's really important that there's complete transparency on the side of the institution. This allows the HTA to thoroughly investigate it and just make sure that it never, ever happens again. So they are the 4 guiding principles set out by the Human Tissue Act and regulated by the HTA. So whenever I talk to anyone about dissection, I know that there are certain questions that everyone wants to know the answer to. So I just wanted to cover a few of the main ones that come up quite a lot. So I want to cover, where do they come from? Where do our donors come from? How are they preserved? Does it smell? Is a common one. And do people faint? So where do the donors come from? So across the UK, lots of institutions have their own bequeathal processes, which means they coordinate it all as an institution. And depending on what your postcode begins with, determines which institution you contact if you're interested in donating. The south of England is a little bit different because it's all coordinated centrally by the London Anatomy Office. So the London Anatomy Office look after the donations for about 8 medical schools or universities in the south of England. So donors would get in contact directly with them. The London Anatomy Office would then send them out all the information they require. And then when they do die, the family call up the London Anatomy Office and they work out where would be best to send them across the south of England. How are the donors preserved? So you might have heard of embalming, and embalming is the method that we use to ensure that the donors are preserved. And this means that donors can stay in the dissection room. They don't need to be refrigerated or frozen throughout the entirety of we keep them out for the first year at least, but they could be out there longer. So the way embalming works is you use the body's own circulatory system to get a fluid all the way around the body. So as I'm sure you know, we have blood vessels that go all the way to the tips of our fingers and the tips of our toes. Blood has to get everywhere. And so it does a very good job of dispersing this fluid throughout the entire body system. To do this, you go in through the carotid. So this is the big artery in the neck, or sometimes in through the femoral artery, which is close to the groin. There's a couple of different types, and different universities use different methods to preserve their cadavers. So the most common type is the traditional or formalin fix embalming. And formalin is just formaldehyde, which you might have heard of, mixed with water. And traditional fix embalming results in something a bit like we can see in the image on the left. So this image has come from an atlas of a donor. And just to orientate you slightly, just going to put on the laser pointer. So just here, we can see the heart, but it's sitting within the pericardial sac, so we can't see the heart itself. Up here, we have a number of blood vessels. So this is actually the superior vena cava going into the right atrium there. Just here, we can see an example of a nerve. This is the phrenic nerve going to innervate the diaphragm. And here we can see the lungs. So you can see that this type of embalming results in slight discoloration. Everything looks a little bit faded, and it also really dries out the tissue, which is really great because it makes dissection a bit easier. But the downside is it looks less like what it does in life. Soft fix embalming is very similar. It retains slightly more moisture. The donors remain slightly more flexible, and it means that the colours of the organs are slightly more true to what they would be like in life. And then finally, teal embalming is it results in a soft fix. It's just another method. So they disperse the fluid around in the circulatory system, but then the donor rests in a tank of a different fluid for up to 6 months. So just another thing to consider investigating when you're thinking about medical schools to apply to. Okay, the next one, this is probably the most common question I get, is does it smell really bad? I'm not going to tell you there's no smell, but it's really not as bad as I think anyone would be imagining. So what you are smelling in the dissection room is the embalming chemicals. You get used to it very, very quickly. And especially if you're in a nice new lab environment, the air turnover is so quick that you can barely smell anything at all. If you are really, really worried about it, if you are going to go and learn anatomy through cadaveric dissection, great tip is just to put a bit of Vicks or something that smells really nice on your top lip, and then there's no problems at all. People get used to it very, very quickly. If you're wondering why I have this image up here, it's because this area here, if you weren't able to work it out, is actually what the nose looks like. So this is a radiology scan. So if I was to take a slice about here, so it goes through the nose and through the eyes, this is what it would look like. So as I said, in the middle, we can see the nose, and we've got these things called conchae in the middle of the nose that help to direct the airflow. So these are the conchae just here. We've got 3 of them going up. We can also see the orbit or the eye socket just here. And this space here is something called the maxillary sinus. So I'm sure you've all heard of people saying, oh, my sinuses are blocked, or I've got a sinus infection. We've got many air spaces within our skull, and this is this is the largest one that we have. But yeah, I was quite surprised when I saw it for the first time at quite how big a space that is sitting within our skull. Moving on to the do people faint question. And as you heard in my introduction, this is part of what I'm interested in my PhD. So any questions about this, I'm very, very happy to talk at length about. A lot of research has been done into the different reactions of students to this experience. And I just want to reassure you that 1, a very small minority of people really do struggle. 2, out of those that do, almost all of them are able to acclimatize to the experience within the first couple of sessions. You get used to it very, very quickly. And 3, everything is fine and everything is normal. We see absolutely every reaction in the dissection room. And it doesn't mean you're going to be a good or bad doctor. It doesn't mean that you're not going to be able to cope with anatomy learning. Everything, any reaction is absolutely fine. And please don't worry about that if you are feeling at all anxious about it. What's really nice is when you do analyze this, you find that actually most people are feeling enthusiastic. A lot of people are feeling indifferent or nothing at all. And the people that are feeling anxious or scared or repulsed are very, very small. And again, by the second or third session, almost everyone is completely fine with the experience. However, if you do come to study at BSMS, there is a lot of support available. So if you do end up struggling, please do let us know. And we are able to support you through the process. Okay, so why do we teach through dissection? One, we're all humans and we don't look like textbooks. So textbooks can show us the most common patterning of different blood vessels and the most common orientation of the organs, but we are all amazing because we are all so different. And learning just through textbooks, you would lose that appreciation for how much human bodies actually do vary. So in the module that I run in year 1 of the medicine course, I ask the students to all note down any variation they find in their donor. And that means that at the end of the year, everyone can go round and observe all of the different variations. And one of the most amazing things about it is just how many we are able to observe during just that one module. So my module is looking predominantly at the chest, so below the neck and above the abdomen. Second is pathologies. So it's such a privilege to be able to explore someone's body so thoroughly, and you will learn more about them than any doctor during their life was able to know. You'll know more than they did. You'll know more than their doctors did. And quite often, donors come in that have died of different clinical conditions or different pathologies. But often we find ones that they probably had no idea that they had as well, and probably weren't affecting their everyday life. So really, really interesting. And although I don't have a clinical background, this is why we employ our clinical demonstrators. So we have 10 demonstrators who are all practicing doctors who come and demonstrate for us part-time. And they're an amazing source of knowledge whenever we find any pathology in the donors in the dissection room. Third, lots of research has shown that hands-on learning is the best way to get to grips with anatomy. And tied in with this is that it really gives you that 3D appreciation of the human body. Also tied in with this is it gives you the manual dexterity skills. So you're learning to use a scalpel, you're learning to use forceps. And just by going through this process, you really do build up a really good mental image of how the human body is put together. And yeah, but coming back to the 3D appreciation aspect of it. And finally, teamwork. So we ask our medical students to work in the same group throughout the entirety of their first year, and not just the same group, but also with the same donor. Okay, so I've spoken a lot about cadaveric dissection and the benefits of that, but that is not the only way that you're going to learn anatomy. And in some medical schools, you don't learn through that method at all. It's all done through these other methods. So what else is available? 3D models. All anatomy departments will have a vast array of 3D models. But also now there's a real rise in virtual 3D applications. And these are getting better every day. It's really quite remarkable to see what these 3D applications can do now. And this is what I'm going to spend the second half of this talk doing, using Complete Anatomy, which is the software that we subscribe to at BSMS. Another method that we don't use, but a lot of medical schools do, is anatomage. So anatomage allows you to perform a virtual dissection on a table using this virtual model. So it really replicates the dissection experience, but virtually. To learn anatomy as well, we do a lot of imaging, so a lot of radiology, maybe MRI, X-ray, CT, but also ultrasound. So this is something that we use a lot at Brighton and Sussex Medical School. You'll learn anatomy through ultrasound in every single module during first and second year. So the image here I've got up is of the heart. You can see the right atrium, RA, and left atrium, and then the ventricles at the top of that image as well. And then finally, surface anatomy. So we all have bodies, we all have the anatomy, and that's a great resource to use. So I just want to go through a quick example of that with you. So if you are able to, where your clavicles come towards the midline, they articulate with something called your sternum, which is often referred to as your chest plate. So if you put your finger right in the middle of your clavicles, you should feel something called the jugular notch just there. If you feel down from the jugular notch using your fingertips, you should get to a point where you feel a ridge. So on me, it's just about here. I can feel a ridge. And this is where the manubrium of the sternum, so one bone of the sternum, articulates with the body of the sternum. And the reason that this is a really important one, and it's the one that I've brought up today, is because it's how we find our second rib. So it's very hard to feel for individual ribs. The first rib is very hard to palpate or feel because it's under the clavicle. But this landmark here articulates or joins directly with the second rib. So if you are a doctor and you need to work out which rib is which, you're always going to start from rib 2 by feeling for this sternal angle. So that's just one example of how we use surface anatomy to aid in our anatomy teaching, but it does come up quite a lot. Okay, so specifically at BSMS, in year 1, we have 3 terms and we teach in year 1 through dissection. So this is hands-on doing the dissection yourselves, but guided by faculty and the notes. Term 1, we do an introduction. This is where you look at a bit of everything just to kind of orientate yourselves. Term 2, we move on to the thorax, and then term 3, we look at the abdomen. It's slightly different in year 2 because we stop dissecting and we move to prosection sessions. So this is where you're viewing the pre-dissected specimens. And you can see the different topics covered in each term on the slide there. Alongside cadaveric dissection and prosection, we also use a lot of the things I've just spoken to you about. So we use plastic models, we use ultrasound, we use living anatomy, radiology, and complete anatomy, the 3D model. Okay, so I'm just going to pause there to check on the Q&A. So if you do have any questions specifically about dissection and how it's taught, how it's used to teach anatomy, or anything I've spoken about already, do pop them in there. I can see there's one. So we've got one question come through already. When we dissect, are we doing it alone or are we doing it as a group? Really good question. So you're never doing anything alone in the dissection room at all. So you're in a group of 10 other students, but there's also at least one member of faculty and at least 3 or 4 demonstrators around the room as well. So you'll always have a lot of support. The next question that's come through is, why does BSMS choose to do 1 year of dissection and 1 year of prosection? I'm just going to stop sharing for a second. So I think this works really well because they achieve different things. So dissection is amazing to develop the manual dexterity and to really explore the body. However, it's not the most time efficient way to view the really delicate structures. So when you're looking at the branches of nerves and the branches of blood vessels, they're very hard to dissect out, especially within the time allowed for the session. So that's why in year 2, when the content gets a bit more complicated, especially when we're looking at the head and neck anatomy, there's a lot of very fine structures in that region, we switch over to prosection sessions. So in my opinion, it's the best of both worlds. But some people have a preference for one and others have a preference for the other. Okay, so I think I'm going to move on now. And again, we will have some time at the end, hopefully, to answer any others that come through. Okay, so just before I move on to complete anatomy, I just want to ask you to quickly sign up to Slido. So you can join this Slido quiz either by scanning the QR code on your phone or by going to slido.com and typing in that number. And while you're all figuring out how to do that, oh, and by the way, when you join up, you're not going to see anything yet. I haven't made it live yet, so don't panic. You are in the right place. I've just got to click the go live option. While you're all doing that, how long are the anatomy labs normally? So when we do them at BSMS, they are 2 hours long. They can be slightly shorter in the second year to an hour and a half. And we see the students approximately every week. In term 1, it's slightly less than that. And in one of the terms in year 2, it's slightly less than that. But a good average is about once a week. So you'll have a lecture on Monday that will give you all the content for the dissection session. And then on Friday, you'll perform the dissection based on what you've been learning in the lecture. Okay, so I'm just going to switch over now, and don't panic if you haven't got the code, because I believe it is on the other screen as well. So I'm going to just ask you 2 quick questions, and I just want to see how much you already know about the head and neck before I get started. This is all anonymous, so please do just have a go. No one's going to be judging whether you got it right or whether you got it wrong. Okay, so I'm going to open up the first the first question now. So it should pop up on your screens at this point. So how many bones are there in the human skull? Is there 1, 5, 12, 17, or 22? What do people think? Amazing. So I'm very impressed. I thought I was going to catch you all out with the 1. I thought you were going to be like, oh, it's the skull, of course. The answer is 22. So amazing for the people that got that. And 17 was a great guess, though, as well, for the people that picked that one. So there's 22 bones in the human skull. We divide it up into the bones that surround the brain. We call that the cranium. And then all of the little bones that make up our facial skeleton. So there's 14 of the facial skeleton and there's 8 of the cranium. Okay, let's move on to the next activity. So can you name any of the bones in the skull? We've said there's 22 of them. And if you could just put one answer in each response, you should get the chance to submit multiple responses. So how many of these 22 bones is this group going to be able to get? Okay, let's have a look at what people have said. If you're still typing, do finish up. Wow, okay. Loads of you got the frontal bone. That is amazing. Lots of you got the mandible or the jawbone. We've got the ethmoid. I'm very impressed that someone got ethmoid. I didn't think anyone would get that. And the sphenoidal bone. Palate, there's a palatine bone, very, very close. There is a zygomatic bone. What else have we got? Frontal bones. Cheekbone is a good one. It's the colloquial term for the zygomatic arch, which is formed by 2 bones, zygomatic bone and the temporal bone. Temporal bone we've got, though. Amazing. I am very, very impressed. You all are very, very good at your bones of the skull. Which makes my job easy because it means I'm going to be quite quick with the first little bit of teaching I'm going to do using complete anatomy. So thank you very, very much for all participating in that. I'm going to close that now, and I'm just going to switch over to complete anatomy. Okay, so a lot of you don't need me to tell you this, but you've got the frontal bone, which a lot of you were able to identify. This is your forehead bone. Just behind the frontal bone is the paired parietal bone. So we've got 1 on each side. Looking now towards the back of the skull, we have something called the occipital bone. And if you notice, just in the middle of the occipital bone, there's a bony protuberance or a lumpy bit. And you should be able to feel that on the back of your skulls. So that's called the external occipital protuberance. We also have the temporal bone just here. So this is all the temporal bone. And the cheekbone is this part here. So this is the zygomatic arch. Part of it is made by the temporal bone and part of it is made by the zygomatic bone. The last bone that makes up the cranium, so the case that surrounds our brain, is the sphenoid bone. And we can see the sphenoid bone sitting just here. So it forms this part, but also part of the back of the orbit. And this bone is really quite amazing to have a look at. So I'm just going to show you what it looks like in a slightly different view. So here I've exploded the skull to show all of the bones individually. And if I click on this one, This is the sphenoid bone. And a lot of people say it looks a little bit like a butterfly. So you can see its wings, and then it's got its little legs down the bottom there. Okay, so they were the bones of the cranium. We also have a number of bones of the facial skeleton that I'm not going to go through in detail. Oh, sorry, rewind a little bit. Before I go on to the facial skeleton, I just wanted to point out to you that now you know the bones of the cranium, you also know all of the lobes of the brain, which is quite amazing. So the frontal lobe sits under the frontal bone, the parietal lobe sits under the parietal bone, the temporal lobe sits under the temporal bone, and the occipital lobe sits behind or underneath the occipital lobe. Okay, so lobes of the brain correlate to the bones that surround them. Okay, now moving on to the viscerocranium or the facial skeleton. We have a lot of tiny little bones that make up our face. The key ones are the maxillary bone, forms our upper jaw, and the mandible forms our lower jaw. We have a number of different other little ones. We've got the nasal bones, we've got the ethmoid bone, we've got the concha inside the nose there that we had a look at earlier. And just while we're on this model, I've circled a number of different little holes that emerge onto the face. And these allow for nerves, or sometimes blood vessels as well, to travel from the inside of the skull out onto the face. So the face needs a lot of innervation, it needs a lot of nerve supply to get to it. So we have little holes in our skull, and we call these foramina. If we have a look at an example of a nerve, so this nerve is called the trigeminal nerve. It's a cranial nerve, which means it comes from the brain and the brain stem. Here we can see the main branch of the trigeminal nerve, and then it splits into the ophthalmic, the maxillary, and the mandibular. And these are going to provide sensation to the face. So the ophthalmic does the forehead and the upper eyes. The maxillary does the upper jaw and the nose, and the mandibular does the lower half of the lips and the jaw. But I just want to show you how these nerves travel through the skull. So here we have the ophthalmic nerve. And if we follow it around to the other side, we should be able to see it emerging out onto the face through this tiny little hole or foramen that we can see just here. So this is the supraorbital nerve, and it's a branch of the ophthalmic division. If I go back now to the maxillary nerve, if we have a look at it from this angle, you can see it's still highlighted there in pink. But this tiny little branch here, there, is the infraorbital nerve. So the supraorbital came out above the eye socket. The infraorbital is coming out through this tiny little foramen just underneath the eye socket. And then finally, just to show you the most interesting nerve, I think, is the mandibular nerve. Here we can see the mandibular nerve branch. So this is the third division of our trigeminal nerve. And this nerve does a lot of things. And we're not going to cover all of them. I just want to show you one that I find quite interesting. And that is this branch just here. So this is the inferior alveolar nerve. So inferior means below. Alveolar tends to relate to the teeth. And this nerve actually disappears inside the mandible. It travels within the bone of the mandible. And you can see it gives little branches up to innervate the teeth along its course. And then it emerges onto the face as something called the mental nerve. So this is the mental nerve coming out here through something called the mental foramen. Okay, so I think I'm going to conclude the talk there, just so we have a little bit of time for questions. So if you do have any questions about anything I've spoken about at all, please do put them in the Q&A box, and I will be very happy to answer them for you. While people are just typing, I just want to show you one more thing, just because it's kind of cool that complete anatomy can do. Here we have a muscle called the temporalis muscle. And what I really like about teaching with this software is there's a little button here that says motion. And any muscle that we select, we can then see how that muscle works to provide the movement that it provides. So the temporalis muscle, its lowermost fibers help to retract the mandible, so bring the mandible backwards, whereas its more anterior fibers, the ones towards the front, are going to help with elevation of the mandible. So whenever we think about muscles and the way that they make a movement happen, we're thinking about the way that those muscle fibers are moving. And if we're moving one point towards another point, how is that going to affect how the bones move? So yeah, really good software. I do not work for Complete Anatomy, just a big fan, and really think it helps teach what is a very visual and very 3D subject. Okay, so I'm going to stop with that now. And I'm just going to have a quick look in the Q&A to see. Okay, so we got a couple of questions. Would the feeling we get when learning to dissect be similar to that which we would experience when doing surgery in terms of tissue resistance, for instance? So this really does depend on the embalming technique that is used. Traditional formalin fix was the drier one. It was the example that I showed you in the image that I provided, is really quite different to how it would be in surgery. So you don't get there's a thing called fascia, like a connective tissue throughout our entire body. And in surgery, they rely quite a lot on fascial planes. It helps to find the plane at which the surgeon should be operating within. And they're all lost a lot with the traditional formalin fix. Soft fix goes part of the way to making it more similar to surgery. So it's definitely not the same, but it's much closer to what surgery would be like. We also, something I didn't speak about is in our anatomy lab, we do offer fresh frozen dissection as well, but that would never be for teaching purposes. That's only for really specialized surgeons who need to try a new technique or hone an existing technique using our donors. So as well as teaching all the students, we also run a lot of surgical courses in the anatomy lab, and they would be the only ones that are using the unembalmed donors, so the fresh donors. And that is because embalming does disrupt how the tissue looks, and so it's not identical to how it would be in surgery. Couple of questions about Complete Anatomy, which is great. So all of our students have access to Complete Anatomy throughout their time studying medicine at BSMS. A number of other medical schools also use this software. And if they don't use that software, they almost definitely have an alternative. There's a number of different products out there. The great thing about Complete Anatomy, though, is all of the screens that I've shown you today, I can provide a link to them and I can put them in my PowerPoint slides. So when I'm giving a lecture, my students can go directly into the app and see exactly how I've built and labeled the model. So the software is Complete Anatomy. It's owned by Elsevier. Does BSMS use soft-fix formalin or teal? So it uses soft-fix embalming. However, that's quite a new change. One of the reasons we changed is it has lower levels of formaldehyde, which is really great for prolonged exposure. As a student coming in, you never need to worry about formaldehyde. You're in there for such a short amount of time. The levels are always well below the legal limit, and it's regularly tested. But for people that are working in the lab all day, every day, over many years, prolonged exposure to formaldehyde or formalin can be problematic. So one of the reasons we switched was the lower levels. But this means that some of our pro sections, so we can keep pro sections for up to 10 years, maybe even longer if they're well looked after. A lot of our pro sections are still created using the traditional formalin fix, but all the donors that are being dissected are all soft fix. And the next question was also about embalming. What are the main ethical issues of using cadaveric dissection? It's something that has to be treated with so much thought and care and dignity and respect. There are a lot of things that can go ethically wrong, but as long as all the principles outlined by the HTA and the Human Tissue Act are followed, that really shouldn't happen. One of the key ones that's being talked about a lot at the minute is during COVID, a lot of us were teaching online. So we were sharing images of our cadaveric specimens with our students online. And how do you navigate monitoring that? How do you make sure that students aren't posting these on social media and taking screenshots and using these images in ways that they weren't intended? So our donors, the only people that can see them, and it's why I've not put any images from our lab in this session today, are people that are listed on the license. So you have to be studying medicine or an allied health profession, or anything else that has a genuine reason to be learning anatomy. We can't just invite anyone into our lab. So access to the lab is really important. The way that images are treated and stored online is really, really important. And I know I'm talking very much from a UK-centric standpoint. The rules and regulations in different countries vary drastically. And that's another thing that needs to be considered as well, because sometimes we import body parts. So we have to think about the rules and regulations in the country we're importing from and make sure that they align with what is set out with the Human Tissue Act in the UK. So for the whole of year one, are we only dissecting one donor? Yes. So you are assigned to one donor and you will work on that one donor in your group of 10 students throughout the whole of year one. You are often encouraged to go and have a look at all the other donors. It's not like you're stuck at that table. And there are opportunities to, I often have like one station with a few pro sections on for you to go and have a look at during the session as well. But yeah, all of the dissection you do will all be on one donor. Do you know which unis do not use cadaveric dissection? I do not have an up-to-date list on this, unfortunately. Quite a few of the newer medical schools choose not to build new dissection suites. I think Plymouth is the only example I can think of off the top of my head that currently doesn't teach with dissection, but definitely something you should explore when you're thinking about applying to medical school. Does the pro section happen in front of you? So the teacher will take the brain apart in front of you, or will they prepare the anatomy prior to the session? So a bit of both. Sometimes we do demonstrate dissection, but that would be considered dissection, not pro section. So pro sections often take, I don't know how to best estimate it in hours, but they can take months and months to create, doing like 5 or 10 hours a week. So they take a lot of time to prepare. So they're all done well in advance, and it's why we take such good care of them and we keep them for as long as we possibly can, because a lot of work goes into making a pro section. In our team, we have a pro sector who one of their main job roles, definitely not their only job role, but one of their main roles is to continually create pro sections, but all of the staff in the anatomy team all contribute to that as well. We do sometimes have opportunities for students to create pro sections like over the summer break, but that's not a guarantee, unfortunately. It does vary a bit year by year, depending on how much we have available for students to dissect that year. So if it's something you're really keen to have a go at, there often is opportunity, just not a guaranteed opportunity for everyone. Do we get to know about the identity of the cadaver, or are they kept anonymous? So traditionally, they were always kept completely anonymous. However, at BSMS and at a lot of other institutions, including Trinity College in Dublin, we actually do tell the students the first name only of the donor. So we don't tell them the full name. We do keep the anonymity of our donors. But if you would like to find out the first name of the donor that you're working on, then you are able to do so during the first session. The other things that you get to learn about your donor, so you get to learn the age they died. You get to learn what was put on their death certificate. So what was their cause of death? You get to know whether they gave us consent for retention, which we haven't discussed yet, but I briefly mentioned we only keep bodies for 3 years under the Anatomy Act. If a donor specifically says they're okay with us keeping a part of their body, then we are able to do so. So we put that on the information for each donor as well, whether they've given consent for that. And you find out whether they gave consent for images or not. If they have said yes to that, that definitely doesn't mean that you can take images in the lab. It just means that we're able to take images and we can use them for stuff like lectures. Why is BSMS a great university to learn anatomy at? Biased answer, but the anatomy team, we're all very lovely, all very passionate about what we do. We also have amazing facilities. So I love working in a relatively new anatomy lab. We've got some great technology in there that allows us to show from a bird's eye view the dissection onto all of the screens around the room, which is excellent. The other really great thing about BSMS is it's one of the universities that uses ultrasound the most to teach anatomy. So if that's something you're really keen at getting some experience in, it is something that BSMS offers throughout years 1 and 2, unlike a lot of other places. Last couple of questions and then we'll wrap up. I realize we are at time now. So when you first dissected a person, how did you feel? I was terrified, and I don't want to say that to make you more anxious, but just to be completely honest about how I felt, and it's what has made me interested in this topic area as a PhD student. I was really, really nervous beforehand. I was really, really nervous coming into the room. I was very nervous when I was in front of the table and the donor was still covered. But what was quite amazing was 20 minutes in, once you're actually performing the dissection and you're focused on the science and you're focused on the learning, it amazed me how quickly I overcame those feelings and felt completely at ease, and was able to just, get on with what I was doing. So I found that really interesting, going from two real extremes of emotion quite quickly. And again, everyone reacts differently. Every reaction is fine. Just try not to worry about it too much beforehand if you are feeling anxious. And then finally, what is the range of people that are being dissected? Does it truly represent the diversity of people that live in Britain? That's an amazing question. And actually, I'm doing some research on it right now. So no, at the minute, it doesn't represent the diversity of people that live in Britain. For a couple of these, it's for logistical reasons. So, for example, unfortunately, we can't accept people who are very overweight just because it makes the dissection really, really difficult to perform. We also have a limit on height. You can't be over like 6'3" because our tables aren't that big. In terms of race, we do get some racially minoritized people coming into our lab, but it is less than what the population is like in the UK. One reason it might be, and again, I'm about to conduct some research, so I don't have the answers right now, but hopefully this will be a step towards working out why this is the case, is that most of our donors are from the elderly population. So most people that sign up to donate their body for anatomy are also very willing to be organ donors, and that will always, always take precedent. So if a person does die relatively young and their organs can be used, then they won't be used for anatomy dissection. So a lot of our donors are more elderly, and that might be one of the reasons why the diversity of those donors doesn't represent the diversity of the population in Britain. And then, sorry, I've just seen one more come through, so I'll quickly answer it. I imagine we sometimes run into unexpected events like unknown surgical hardware. And quite frequently. We often get pacemakers, which is really interesting because you can follow the wires through the vascular system into the heart. We've seen a few replaced hips, a lot of unknown surgical hardware as well, that it's quite hard to exactly work out what the role was. Another really interesting one is we get ball and cage valves that are valve replacements that have been discontinued, but people are still living with them. And it's really quite amazing to see those when we encounter them. Okay, so I'm going to wrap up there. Unfortunately, we're slightly over time, but I hope everyone enjoyed the talk. And thank you for having me.